you will see the patients are coming with one or the other chest complaint within the two mediastinal surface of the pleura, in front of the vertebral column and behind the sternum is called the mediastinum. The space in between the mediastinal surface of the mediastinal pleura that covers the mediastinal surface of the lung with the sternum in front and the vertebral column behind. You will see that there are complaints from the patient of, write down, dysphagia, dyspnea, intercostal neuralgia and paralysis of diaphragm, together with various infections, tumors and inflammation of lymph nodes. All these forms mediastinal symptoms. Whenever there is an X-ray and there is an haziness that suggests a mediastinal lymph node or a group of mediastinal lymph nodes, you will be very much puzzled where from this tumor is arising, whether it is benign or malignant. Whether it is benign or malignant. If it is directly seen to be coming from the lung, then you can do biopsy and the histopathological diagnosis could be there. But when it is within the mediastinum, you will not be able to do a biopsy. It is not possible to do a biopsy or fine needle FNAC, that is the fine needle aspiration cytology. You cannot do a test like this. So you have to depend on X-ray plates, CT scan, MRI and the clinical symptoms. What are the clinical symptoms? That is the dysphagia, dyspnea, hoarseness of voice, intercostal neuralgia and paralysis of diaphragm. Alright? Paralysis of diaphragm. Now, we need to define the space of mediastinum and understand where in books what it is written in mediastinum, that is enumeration of 1, 2, 3, 4 like this. Enumeration of the structure within the mediastinum in 1, 2, 3, 4 like this. But you will not be able to understand the location of the structure, alright, and the flow of the structure, where from it is originating and up to what is its extent. So you need to know the mediastinal structure in that version. First, try to understand the boundary in a cross-sectional plane. Try to understand the space, that is, these are the two spaces. These are the mediastinal pleura lining the mediastinal surface of the lung. In front there is sternum and behind there is vertebral column. Alright. Now this is the mediastinum. Now there are divisions and subdivisions. Somebody please come here. Take the duster. Oh, thank you. From the T1 vertebra, there is a first rib with the anterior part of the jugular notch on either side. The first rib attaches. So this makes the inlet of thorax. This makes the inlet of thorax. So this one is the inlet of thorax. This one is the inlet of thorax. The next space is divided into, that is the mediastinal space, is divided into superior and inferior part. The inferior part, that is the inferior mediastinum, is again divided into anterior mediastinum and the posterior mediastinum, right? You see, the boundary of superior mediastinum is the imaginary line at the level of T2, lower border of T2, to the jugular notch. This one is the jugular notch, to the lower border of T4. In the examination, it is always asked what is the vertebral level of sternocostal junction and how can you palpate for the ribs. How can you palpate for the ribs? You have undergone classes on ribs and sternum. Somebody please tell me how to palpate for the ribs. From the, not from the manubrium standing. One thing is thick, that is at the junction of manubrium standing. There is second rib. Then you count second, third, fourth, fifth, sixth. All right. So lower border of T4, that is the junction between T4 to T5 vertebra, is the junction between the manubrium sternum and the body of sternum. This junction is the manubrium sternum and the body of sternum. So the space above this is the superior mediastinum. So in front there is sternum, behind there is vertebra with the longitudinal, anterior longitudinal ligament, longus colli muscles. All right. Above there is the inlet of thorax, and below there is an imaginary line at the level of T4. Right. This is the boundary of the superior mediastinum. Now the inferior mediastinum is bounded, number one, in front by the body of the mammalian style, behind by the T5 to T8 vertebra. All right. Above by the imaginary line at the sternal angle, and below by the imaginary line up to the ziphisternal joint. All right. So this is the inferior mediastinum, which continues up to the L1 and L2 vertebra. If the posterior mediastinum is taken behind the dome of the diaphragm. All right. This is the diaphragm. Diaphragm is attached. The crash of the diaphragm is attached on the right side up to L1, L2, and on the left side up to L1. All right. Now the esophagus comes like this, and trachea bifurcates before reaching the diaphragm. Trachea bifurcates above. And here will be we need some extra color to draw, otherwise I get demotivated in drawing the diagrams. Here lies the pulmonary trunk. Do a transverse section of, this is transverse section of right lung. What you see, this is the medial surface of the lung with pleura. Here is the ascending aorta, this is the superior vena cava. Behind there is vertebra, there is esophagus and trachea, and in between the junction of esophagus and trachea, there is the right vagus. This one is the right vagus, and below it is coming out the right phrenic and the pericardiophrenic vessels alongside of the heart. I have not drawn the heart here. All right. And anteriorly, you see the sternum with the costal cartilages and the internal thoracic artery and vein. Can you label this diagram? This is the right lung, these are the two folds of the pleura, this is the mediastinal pleura, this is esophagus, this is trachea, this is the vagus, this is the thoracic duct that crosses at the level of the sternal angle from right to left. Now this is ascending aorta, this is the superior vena cava. All right. Now just remember the position. I will draw another figure. The mediastinal symptoms, that is the dysphagia, dyspnea, hoarseness of voice, intercostal neuralgia, and paralysis of diaphragm. No X-ray. What is the important? No X-ray can diagnose it, no CT scan can diagnose it, no MRI can diagnose it. So doctor is at TG. Doctor is at TG. They just are unable to do anything to such a patient. Have you seen? Because it is not a place to do an FNEC. Mediastinum में तुम्ही FNEC, you will not be able to do an FNEC or a biopsy. In abdomen you can put a trocarate cannula to take out some liver tissue, all right, some kidney tissue. But in this mediastinal space, there are so many vessels, so many nerves, so many branches of vessels that you will not be able to do a FNEC or a biopsy. Got my point? And there lies the trouble to diagnose mediastinal symptoms. Got my point? All right. Let me come to next day.